Hi, Be Health Empowered family. Welcome back to another episode of Excuse Me, Doctor. My name is Dr. Melissa Clarke, and we are here each and every Monday night Eastern Time to welcome you and talk about the issues as they relate to your health. And here we deal in fact and scientific information. We're not looking to talk about misinformation or speculation. As a matter of fact, we debunk myths that are floating around out there on social media every week. We're streaming on YouTube and Facebook. I want to welcome all the new folks who are tuning in tonight. Please, if you're tuning in on YouTube, hit that subscribe button. And if you're joining us on Facebook, please hit like. I really appreciate you for that. So the other thing about this show, if this is your first time, we take questions. So please remember to put your questions in the chat, whether you're on YouTube or whether you're on Facebook, and we're going to get to them during the course of the hour. So thanks again for joining us. Now, it's March 1st, but we weren't here last week for the last Monday of Black History Month. So we are going to do our Black History Month fact. And since today is the beginning of Women's History Month, we are going to talk about a very special Black woman physician whose name was Dr. Rebecca Lee Crumpler. She was the first female African-American physician in the United States. She lived from 1831 to 1895, and she began her career in medicine as a nurse. But in 1860, she became a pioneer by applying to and getting accepted to the New England Female Medical College. She graduated in 1864, and when she did that, she broke medicine's color-gender barrier. There were about 50,000 physicians in the United States at that time. Only 300 of them were women, and they were all white until Dr. Crumpler came on the scene. But she didn't stop there. At the end of the Civil War, she left the relative safety of Boston, where she was practicing, and went down to Richmond, Virginia, the former seat of the Confederacy, to provide health care for recently freed Black people. She wrote the first medical textbook by an African-American author. So it's 156 years later now. We as African Americans are 13% of the population, but Black women physicians are only 2% of the over 877,000 practicing physicians. So we still have a long way to go, but thank you, Dr. Crumpler, for getting us started. So that's the Black History Minute. And I am now going to launch into our weekly recap. And joining me, as usual, are my wonderful co-producers, Ms. Lila Mays, coming from the West Coast, and Mr. Wayne Bruce coming from downstairs on the East Coast.
Downstairs where? That could be
on the East Coast.
Hell,
to join me to join me as we talk about what's happened this week that you need to know. So kick us off, Lila.
Indeed. So, Dr. Mel, I heard there was a little bit of a dip. Yes? Have the numbers decreased?
Yeah, well, we always start off. Yeah, they have decreased. They have decreased. You're absolutely right, Lila. But, with that decrease, we have only fallen to where our peak was last summer, which at that time was the highest we had ever achieved in terms of new cases. So practically what this meant is we've fallen for 250,000 new cases in the middle of January, down now to about 60,000 new cases a day. So it's an achievement, but it's nothing to write home about. We still really need to continue. And even in the last 2 or 3 days, we've actually started to see a little uptick. So we need to continue to double mask. We need to continue to wash our hands. We need to continue to keep 6 feet apart.
Indeed. So that's to stop the spread. What about the number of deaths?
So that President Biden last week marked that grim milestone of us passing 500,000 deaths. But even since then, we've still had 12,000 deaths just since last week. And altogether, As far as African Americans, 70,000 plus deaths of African Americans.
Gee whiz, gee whiz. So Dr. Mill, so that's cases, deaths, and what about, do we have numbers on how many people have gotten vaccinated to date?
We do, and it's looking good. We're still over 1 million vaccinations a day, which translates to about 24 million people having had both doses of either Pfizer or Moderna. And that's about 7.5% of the US population. And as far as people who've gotten their first dose so far, which I think somebody on this call, on this show, that applies to 73 million people who've gotten their first dose.
I got mine.
That's awesome.
And it didn't kill me. And this horn that's growing out of the middle of my head, nobody can see.
Producer.
Okay. There is no horn on the middle of his head for those people who are just listening.
Okay, so that's fantastic. The vaccine is rolling out. So Dr. Mill, should women who are pregnant get vaccinated? And if they do, what kinds of side effects possibly might there be?
So this is a deal. Pregnancy raises a woman's risk of getting severely ill if she catches coronavirus. There's a risk of going into labor early and having premature birth or miscarriage, or for the mom to end up in the ICU. So as far as the vaccine is concerned, there were not pregnant women who were enrolled in the initial Moderna and Pfizer trials because we typically try to protect, pregnant women. So we don't have a lot of data. But we do know that the Specialty Society for OBGYN has said that pregnant women who want to get the vaccine should go ahead and get the vaccine, especially if they're in high-risk groups like healthcare workers, or they have an underlying condition like diabetes or high blood pressure. There were 23 women in the trials, though, who got pregnant. So that myth is circulating on social media. The one about, the coronavirus vaccine makes you have miscarriages. There's absolutely no evidence for that.
Or make you.
Oh,
okay. When you got vaccinated, it was a young lady who was pregnant there, and she said her doctor had told her to get vaccinated. So
yeah, she was a dentist, and she works in people's mouths, and she knew her risk was high, and she was about 8 months pregnant, and she was like, no, I'm gonna go ahead and get this. And one other thing, they have tested the vaccine in pregnant animals like rats and rabbits, which is sort of the first stage, and they've had absolutely no problems for either mom or baby.
So once you get vaccinated, tell us, how will my life change? I want to go on vacation. I mean, can I go on vacation? How will my life change?
Okay, well, I'll tell you one way it won't change. You still have to wear a mask in public, and you still have to distance from people when you're in public because you don't know the vaccination status of the people around you. But you can socialize with others who are fully vaccinated without masks. Your personal risk of getting hospitalized or dying from COVID is close to nil if you've been fully vaccinated. And for the Pfizer and Moderna, you want to wait at least 2 weeks after fully getting vaccinated. And you can go to church, you can eat out, you can go on vacation to the countries that will accept you. So yes, your life will change, or it can change, I should say.
In saying that, I know the CDC had recommended a 14-day quarantine when you come back, but you say, I see the rules have changed.
Yeah, they have. So this is not for people with symptoms of coronavirus. This is just for people who have been exposed. So if you've been exposed to COVID and you have no symptoms, your quarantine can end on day 10. It used to be 14. So day 10, if you have not had a COVID test during that time. If you did get a COVID test and the COVID test was negative, it can end 7 days after your exposure. Now, when does the clock start? The clock starts the last day you were around the positive person. So if you and your boy were hanging out and he calls you and says, I have COVID, and y'all were hanging out 3 days in a row, you got to go from the last day that you were in contact with him for the clock to start.
Okay.
Oh, and if you've been vaccinated, all that goes out the window. If you've been vaccinated and it's been 2 weeks since you've been fully vaccinated with both shots, you do not have to quarantine if exposed to a COVID positive person.
All right.
That makes me feel better.
You just have to wear a mask.
Talk about this foolishness
wear a mask and
everybody
distance.
is talking about.
So yeah,
all right.
Just make sure you keep wearing that mask and distancing.
Okay.
So I want to remind everybody, make sure you're writing your questions in the chat, YouTube or Facebook. And we're going to move on to our weekly debunk.
Wow.
The weekly debunk. Stopping misinformation in its tracks.
All right.
All right. This is from Girl Bye. I heard the Johnson & Johnson vaccine is inferior. By the time it gets to our community, that's all they're going to say. That's the only thing available because they don't care.
I don't know about that. Excuse me, Dr. Mel. Is that true? Girl Bye.
I think Girl Bye might have it a little wrong. So this is the deal with the J&J vaccine, which we know was just approved. We're seeing that it's 72% effective in the United States trials versus the Pfizer and Moderna vaccines that seem to be 94 to 95% effective. So that's where I think the concern comes in. But this is what we have to realize. It's not an apples to apples comparison between these vaccines. Number one, because they were tested at different times. So the Johnson & Johnson vaccine was tested at the height of the pandemic, which was this past winter for us. And in addition, it was also tested against that more infectious South African strain because they did some of their clinical trials in South Africa. What they found, and remember, Pfizer and Moderna was not tested against that strain. So what they found was that it was 100% effective after about 6 weeks post-vaccination against severe COVID, which would make you end up in the ICU, and death. Nobody died. So that is wonderful. And it's one shot. And it doesn't have to be, deep frozen, so it can be easily disseminated across the country. It doesn't have those special storage considerations. So when it comes to safety, the number of serious safety events reported happened way more often in the placebo group as the folks that didn't get the real vaccine.
Right.
There were 7 deaths in the study. They all happened in the group that did not get the vaccine. In other words, the placebo group. And then finally, as far as does this apply to Black people, they actually had more Black people in the Johnson & Johnson study, partially because it was tested in South Africa. But it was 20%, if you look at globally, 20% of the study population, which is over 43,000 people, 20% of those were Black, I should say. And in the United States, 13% of them were Black, which is right on par with where we are as our general numbers in the population.
I thought you were going to say more Black people got tested because the last names were Johnson.
Johnson. I knew you were going to say that.
No. Please, my listening audience, please don't pay attention to the views of my producers. Don't represent mine.
Right. Exactly.
Disclaimer.
Well, that doesn't. You have debunked Girl Bye's little inferior text there. So
we welcome all debunks and all questions so that we can again try to provide the facts for everyone. And with that, we are going to move into our show for tonight because I know everybody's been anxiously waiting to hear all about the antibodies, vaccines, and treatments, which is what we're going to be talking about tonight. We know that vaccines are one part of this fight against COVID-19, and we've been focused on them to prevent getting severe COVID-19. But how do the vaccines, including Johnson & Johnson, protect you? And what if you do get COVID anyway? Are there treatments out there? And what are some of those new treatments on the horizon? We have with us a really special guest. She is a fantastic physician, Dr. Seble Kassaye. She is an associate professor in the Department of Medicine, which is in the Division of Infectious Diseases at Georgetown University. She's done groundbreaking work in HIV and women's health, and she is now bringing that same level of innovation to the fight against COVID-19. She's one of the researchers looking at whether giving blood plasma of somebody who's recovered from COVID-19 to someone who's exposed or newly diagnosed, whether that can prevent them from getting a bad case of COVID-19. So welcome, Dr. Kassaye. Thank you so much for joining us.
Thank you, Dr. Mel, and thank you for having me. And more importantly, thank you for hosting this show. It's so important to have people like you helping us, make sure that the truth is out there.
Well, thank you. It has truly been a labor of love, and I love my audience. They ask wonderful questions, which also reminds me to make sure that you remember to put your questions in the chat box so we can get to them. So let's jump right into it, Dr. Kassaye. First of all, tell us about what you do, especially in terms of the research part.
Sure. So I'm an infectious diseases physician by training. I work at MedStar Georgetown for inpatient hospital care, and I also do an outpatient clinic. And I also
that's here in Washington. That's in Washington, D.C.,
Washington,
right?
D.C.
Mm-hmm.
Yes. And I also have an outpatient HIV clinic in Southeast D.C. with Unity Healthcare. So I'm a practicing physician, but I also do research. And I like to think of my research in HIV. It's been focused in HIV in women, as very pragmatic research, trying to improve the overall health of people who are affected with this virus. I kind of came of age when HIV was first coming out and affecting people. I was, a tween at that time, and I was really affected by it. And it was a space that spoke to me. And how I came into COVID, obviously COVID found us. We didn't go looking for it, unfortunately. And I was on service in the inpatient setting one of the first couple of weeks when we started to see cases. And I was completely flabbergasted by what we saw. I'd read about the reports, but you see it and you just realize this is completely different. And so I tried to find my niche to apply myself somewhere where there was space for to do something different, to do something that might be useful, that might fill a gap. And also that kind of rounded up the research that we were doing, because the research, a lot of it that we were doing was bringing in products that affect the immune system in different, very nuanced spaces, very fancy biotech type of products. And I wanted to make sure we didn't forget things that we had learned about in the past that had worked, and not to push all of that aside, all for new technology. So when the opportunity to participate in the convalescent plasma came along my way, I wanted to make sure we had opportunities, that we had potential interventions that might be of use to the people that I take care of, cancer patients, immunocompromised.
Hold on one second, because you said convalescent plasma, and I want to make sure that people know what that means. Sure. So as you kind of help us understand what that means for immunocompromised patients and cancer patients, tell us about immunity and what role do antibodies play in immunity, and what is convalescent plasma exactly?
Sure. So convalescent plasma is plasma that we get. It's the liquid part of blood that we can obtain from people. It's people who donate their blood. And what we do is we pull out the antibody containing part of the liquid part of the blood. And for people who have become infected with COVID and have recovered, part of their recovery process includes their body mounting an immune response to the infection. Part of that includes making antibodies, which bind the virus, neutralizes the virus, and it also works by allowing other blood cells that fight infection kind of get rid of the virus too. So it works in multiple ways. Now, when you think about how does the human body work, we're not simple. It's not just one little antibody that does it. There's a whole constellation of things that come together to allow us to get rid of infections. And so all of that is encompassed in that convalescent plasma. It has the antibodies that we can measure. We make sure that we are using antibodies that are in high levels. Some people don't make a lot of antibodies, so I wouldn't want to use that antibody plasma for you. But for the study, we're able to measure high levels, make sure that you're getting, at least a minimal amount. And then we compare it to, there's no antibody in this bag. So when we do these studies, it's very important that we compare giving the product we're studying to giving something, we call it the placebo, that actually doesn't have that product in it. That way, it's a one-to-one comparison for us to understand, does this make a difference?
Right. So when you're looking at someone whose plasma has a lot of antibodies in it, are you seeing any patterns? Like, can you say that, young people under 40 are going to have the plasma that has the most antibodies in it? Or are there any patterns you're seeing with that? Who's making the most antibodies out there?
I believe there's quite a range in who makes a lot of antibodies. And similar to, I think probably the best way for me to kind of address that is, you can have when someone gets COVID, we can have anywhere from no symptoms, you don't even know you have it, to, within a week, you can't breathe and you're in the hospital in the ICU and you pass on. So 80% of people get what we consider mild to moderate disease. 20% get super, super sick, right, and end up in the hospital. But in all of that, there's that range, there's similar range in terms of whether people make a high antibody response. So overall, it's about 70% of people have a pretty high, robust antibody response when we actually measure. But then there are others who get infected, maybe anywhere in that spectrum of disease, but they don't have a lot of antibody.
So, why does giving antibodies to somebody else seem to work? I mean, wouldn't your body destroy them as soon as the antibodies enter your circulation?
Yeah, so fortunately for us, that's not the case. Same as when you get a blood transfusion, for example, the red blood cells that you get in the red blood transfusions, they last for a certain period of time before your body chews them up and gets rid of them. Same as we would do for your own blood cells, but a little bit shorter with the transfusion. So same thing with the antibodies. Our bodies don't actually destroy the antibodies that you receive in convalescent plasma. They stick around for at least a month, we think, but they may last up to 3 months after an infusion, which is great. So when you give it, it doesn't completely go away, and it's able to be there and be active potentially at a time when you really need it the most. So after a natural infection, it takes a couple of weeks for your body to see the virus, to wake up and say, hey, you know what, this isn't right. I need to make antibody against this. It takes time, right? It takes 2 to 3 weeks usually for you to get that response. So you don't have the luxury of time, though, when you have the virus, on the other hand, happily dividing away, infecting more cells, potentially getting you sick.
I call it, the virus makes your cells into a coronavirus factory. So having the antibodies there can be what can neutralize those viruses on contact. So what we're studying is, can we prevent you from becoming infected in a way where we're actually, the virus starts to divide in the cells? Or if you do get infected, because we're trying to catch people within a very narrow window after they get exposed, within 96 hours. And if you do get the infection, will it turn into something very mild, where you don't end up in the hospital, where you don't get very sick? So can we prevent the more severe cases by intervening early? So those are the main things we're trying to study. Yeah. Now, are people signing up for this trial, and are Black people signing up for this trial?
Yeah. So people are signing up for the trial. We've had kind of spurts of activity. Our summer months in the DC area were, we called it our lull, and we loved it. It was very few cases on any given day, so it was super quiet and not good for the research study, but I was really happy about that. I'd rather have no cases. in the fall, when our cases started to go up, then we had more cases, and people did hear about us. People heard about us on TV. They heard about us through physicians. So there are a core group of physicians who are referring in their patients to us, and my colleagues would refer in their neighbors as well. So that was really, really helpful.
Great.
And then you asked about the distribution of the
African-Americans. Yeah.
Yes. So there I haven't been very successful. Part of it may be who we are testing, but in DC, it's a big, we have enough people becoming infected who hear about this. I haven't been successful there. So I would love to recruit people from the African-American community, but understanding that people may have a lot of hesitation about participating. But what I found about the people who participate, and I think this is generally across the board, it doesn't really matter what race you are, is people who come in, there might be something in it for them, but most of them are coming in because it gives them something to do. This is a way that they can help. They can contribute because this thing is just a big hot mess and we got to get out of it. That's why I'm here. And you know what? Yeah, you're hanging up that stuff. And I always joke around with my participants because I'm sure they're scared, right? They're there and they're with me for 3-4 hours, and you're giving them a blood product. And I always say, well, I hope this is the good stuff. And they're just like, yeah, well, I'm here. I'm happy to do it because otherwise I'd just be sitting in quarantine for 14 days. So this way I can be in quarantine and participating, and you call me every other day to check on me. And so it's really, there has to be that wanting to contribute to the greater good for everybody. And so that's really, I think, what helps. But we do need people of color to participate too.
Yeah. So, we hear about this a lot, the need for people of color to participate in any kind of trial. But we know, on a biological basis, at the level of our genes, there's no such thing as race, right? So if there are no real main genetic differences between, say, me and a European, there might be more genetic difference between me as a descendant of somebody from West Africa than you as a descendant from somebody from East Africa in terms of the amount of variation we have in our genes. So why is there such an emphasis for, Black people and Hispanics and Asians to participate in research trials if race is just a social, what I call a social construct?
Right. So I think there are several things to that. So number one, I think we kind of went through it a little bit with what you talked about with the Johnson & Johnson vaccine. Had there not been representation in that study, where would you be left? Would you be left wondering, would this work for us? And to some extent, it's true that, we're 99% genetically similar, but there are differences in how we metabolize products, how our body breaks down different types of medications. And sometimes we learn about that after the fact. So I lament about it for HIV medicines. We need to know, do we break things down a little bit slower? Do we end up with higher levels of something? Is the dosing right for us? And then similarly for women, we bring a lot of things to the market that are tested in 80-90% men, but not women. And then are we biologically different? I think so, right? Our hormones mean that we break things down differently. So I do think it's important for us to be aware of racial differences that may exist. For plasma, maybe it's not such a big deal. But for many other things, it is a big deal. And also for when we bring this to the community, we need to be able to speak to it as well, I think.
Yeah. So, we're seeing the vaccines getting approved, like Johnson & Johnson. We're seeing cases go down, like we talked about in the weekly recap. So why do we need convalescent plasma at all? Where does it actually fit into all of that?
So I was so ready to hang up my hat in December right?
Uh-huh.
Vaccines are here. We're just going to stop everything in its tracks.
Mm-hmm.
And I'm a huge vaccine fan. So I said, maybe we need to just kind of leave this plasma stuff. But, the rude awakening for us was recognizing that this virus isn't really waiting for us to get our vaccines out there, to get everybody vaccinated. It's moving, it's changing, it's evolving. It's evolving away from the type of product we have in our current vaccines. And unfortunately, we're capturing it in that Johnson & Johnson study with the South African variants, the Brazil variants, and those variants are here, right? They're in the community circulating to some extent. We hope our vaccines will still be active, sufficient to keep people from getting very, very sick. But we are going to have to kind of stay current even with the vaccines, right? And so one big thing I recognized is with the plasma, someone who got infected with a virus from 2-3 weeks ago and is able to donate plasma once they fully recover, right? So we wait at least a month for them to recover before we take any blood products from people. They got the up-to-date antibodies. We're not manufacturing those antibodies yet. So then I said, well, maybe this is why they're still doing this study. Maybe that's why we didn't say, oh, we're done. It's important, I think, to have the answer. And I think we still have time to answer the questions that we started out with, to see if there's some contribution, if there's some role for this. It may not be for everybody, but there may be a subset of people where this could be a very important intervention for them.
And I think too, with the Johnson & Johnson vaccine, where we've seen that it's 66% effective worldwide, 72% effective in preventing moderate to severe disease. It's better at preventing severe disease. That moderate sickness can still be, feeling pretty bad and potentially even getting a hospital admission, maybe not admission to the ICU. So if the convalescent plasma can prevent that, I think that's pretty huge. And then like you said, not just the South African and the Brazilian and the UK variants, we got variants right here that are homegrown. I think there's a strain in New York and a strain in California, and the longer that we go on without getting vaccinated, the more opportunity there is for new variants that might not be covered by the vaccine. So I'm glad that you're doing the research. I think it's definitely going to be something. We need all the tools in the toolkit that we can get. Yeah. So you have done some really interesting work around women and HIV, as I mentioned in the beginning. And one of your papers I saw was the relationship between discrimination and missed HIV care appointments among women living with HIV. And, I talk often, and I wrote a book called Excuse Me, Doctor, I've Got What, which is what the show is named after the book. And it's really about helping people be their own best health advocates and empowering them. And so, I've always been concerned. One of the reasons I wrote the book was because I know that some of our colleagues have unconscious bias, and sometimes they treat people from communities of color, not in a way that shows that their life is valued. Sometimes they get the runaround, sometimes they get talked down to. What was your experience? What did you learn from conducting that study?
Right. So that particular study, our lead author was a gentleman up at Brown. And I have to say, I really applaud people who dive into this uncomfortable space, because it is uncomfortable. The questions are difficult to ask. Asking about discrimination by race, by gender, makes our interviewers very uncomfortable. It's hard on our participants to answer because it takes you to a very different place than maybe that safe place you've created. But basically what he found was that when we looked at discrimination using multiple metrics, so either your own experiences of discrimination versus experience that made life harder, all of those things, experiences of discrimination, affected people's willingness to go for a healthcare visit, for an HIV healthcare visit. And I think that's an important distinction, because usually people have really close-knit relationships with their HIV providers, because it's a very self-selected group of people who take care of patients with HIV. But to me, what was interesting was, for those who had experienced discrimination, it affected Black women, white women, Hispanic women in their willingness to go and seek care. So once you feel that experience, it's not discriminating by race, ethnicity, which I thought was interesting. But in some of the other spheres, it was more predominantly African-American women who were having, with maybe if it's affecting your life quality, etc. When we've looked at it within our group, it's something, having trust in your providers seems to be a really important part of women's willingness to go and seek care. And so I think, the health system structures and how we portray ourselves, how we care for people, can make a huge difference in whether people want to show up. And sometimes it's their life is at stake, and they're still not showing up when they feel that discriminatory practice. The discrimination may not just be based on race. Again, like I said, one of the biggest things that people felt discriminated against was by drug use status. So, people can be very judgmental if you use drugs, but we need people who use drugs to show up and get care. So I think, again, like you said, the implicit bias, the explicit bias, all of those things are things that need to be addressed by institutions that provide care.
Yeah. And, it's, this issue of trust is coming up in terms of vaccinations. I mean, we heard a lot about the Tuskegee study as a reason for, people being hesitant to take the vaccine. I think it's also, too, just the everyday experience that Black and brown people have with the healthcare system. It's not always the most welcoming place. And like you said, it's more that we as healthcare providers have to earn people's trust. It's not like you're just going to blindly give your trust to someone. So, I know that also, too, sort of the reasons for people not taking the vaccine, as Black people, all Black people kind of get lumped in together, but we're a very diverse community, even people who are non-immigrants to the United States who are Black versus Black immigrants to the United States. So have you noticed any differences? I know your background is Ethiopian. Yeah. Have you noticed any differences in terms of reasons for people being concerned about taking the vaccine based on the community of African descent that they come from?
To some extent, yes. I think some of those things are some of the concerns are universal. Depends really on where people get information and what space people are making decisions, right? So if you're making a decision on such an important part of your healthcare from a place of distrust or fear, it's very different than when you're making that decision from a place of knowledge and trust. And which is why, the conversations with people are clearly important. Access to healthcare may be variable. So, my patients maybe will text me and say, what am I supposed to do? Or call me, right? I mean, they demand my attention and I give it to them. Women who are of East African descent, they may not have those kinds of relationships with their providers to actually do that. I've also found that culturally speaking, not just with vaccines, but even with some of the physical distancing that we are recommending, when there's a conflict between your culture, how you socialize, how you bury somebody, how you pay your respects with a new birth, to go from this very highly socialized events to, you're not supposed to be near each other, you can't go to church. It took a while, and it took some big hits for us to wrap our heads around, we can't do this. And the clergy are always really key people to engage early on.
Yes. I mean, we've found that in the African American community. We've seen that vaccines, dissemination, they've done a pilot with the Department of Health in DC regarding involving churches. And we're seeing that that's working wonderfully, like gangbusters, because people want to go to church and get their vaccine around people they know and trust. So, yeah, I think that's true definitely across communities. Well, I'm going to go to my producers and see if we have any questions waiting in the wings.
Yes.
We do.
Incredible conversation on antibodies, and I'm learning. I have to learn every week with Dr. Mel. she teaches us every week. So we're going to go to. We have a question from Kathy Sindos. Kathy writes, when will we know how long COVID viral antibodies survive?
And I think that's a great question for Dr. Kassaye. Thank you, Kathy, for that great question.
Yeah. So I think it's going to be variable person to person, but we have some studies that show that you may have antibodies that persist to 9 months, and at least to that extent. And, sometimes even when we don't have measurable antibodies, when we give a vaccine, not only do you make antibodies, but you also train other types of immune cells so that when you encounter that infection, those immune cells can kind of wake up real quick and get you more antibodies before you get super sick. So the antibodies last, we think, 9 months for some people. It may not be for everybody, but then you do have other immune responses that are shored up and ready to go in case you encounter the infection.
Okay.
And just to be clear, that's for vaccination and natural infection?
Right. Yes.
Okay.
Yes. What we know for how long the antibodies last is for natural infection. The studies from the vaccines, we're still waiting on those data. These studies are ongoing, so they're going to continue, most of them for at least 2 years.
Okay.
Right.
I have a question from the West Coast, from Angela Mays. She says, I realize this is not the subject for tonight's show, but I'm wondering where we are with the Oxford AstraZeneca vaccine being approved. I know it's being used in some European countries with success.
Dr. Kassaye?
Either doctor.
Yeah, I don't believe that vaccine has been presented to the FDA for approval. And anything that gets approved in the US goes through that FDA approval process, which is very rigorous. They have to submit everything. Everything gets reviewed, gets analyzed by our FDA colleagues, and then gets shared with a group of experts from all over the US who then weigh in and make recommendations to the FDA. So it's a really beautiful process that they have in place, and that I know it has not been submitted yet for consideration.
Okay.
If we can follow the FDA thing, because I just got in a conversation with a really good friend of mine about this FDA, and he was adamant about not taking the vaccine, and maybe you and Dr. Mel can give me a heads up. I mean, Dr. Mel hears my cry some nights. And he was adamant that he had checked on the vaccine, and it's not FDA. Well, he had checked on both Pfizer vaccine, and it wasn't FDA approved. And if you go to the website, they will tell you it's not FDA approved. Can you guys speak to that?
Yeah.
Dr. Kassaye, yeah, I think he's talking about the difference between emergency use authorization versus full FDA approval.
Yes. So, most of these studies are being approved while there's ongoing data collection from the actual initiation of the study. Like I told you, most of these are supposed to last for 2 years, and they will continue to collect data for that time period. When you reach a critical preset number of cases, you are allowed to ask to review the information and say, does this look so good that it would be wrong for me to just wait 2 years? In that situation, they can do interim analyses during the actual course of the study to make a determination whether or not the bar to actually start using these products is met. But always, 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 there has to be a good safety profile as well. So there's the safety profile that they look at, and then they look at the efficacy, which is how good is it at doing what it set out to do. And I think without a question, with all of these, those have been, these are incredibly successful vaccines in terms of their efficacy, the side effect profile, which, I joke that it can do the shake, rattle, and roll, which is the fever that comes after the second dose of some of these products. But, we see that with other vaccines as well. The efficacy we're talking about, even comparing it to the flu vaccine, these are amazing products, right? So we need to continue looking. We don't have the safety information for the pregnant women, the kids, etc. But so here they give this emergency use authorization, and that's a distinction from a full-on approval, which usually would happen at the end of a study when they have every single last piece of data already submitted.
Okay.
And let me, if I can, it was a great explanation, which I think is what really, Lila was going to say. But I'm going to add one more thing. We are in a frigging pandemic. Yes. 500,000 people have died. And the reason for the word emergency in emergency use authorization is we are in an emergency. And yes, that's why the EUA process was established for times such as these. It was established after 9/11 to allow for the flexibility to do just as Dr. Kassaye elegantly explained. When the stuff is hitting the fan and we need something to help us out, we can get something that we are continuing to evaluate. But so far, from what we see, it will save lives. And I just had to add that on to the end. I think we could do a good cop, bad cop thing here.
Thank you, Dr. Mill. I just want you nailed it, both of you. And to Wayne's question and to his point, the reason we do this show is to combat misinformation and to get this information out there. But that was a great question, Wayne, and that was such a great explanation about, listen, we've met the criteria. We are in an emergency. We are in a crisis. That's the whole point. So if it looks like this is going to help, why not use it?
Yeah. There's definitely a lot of, this isn't business as usual,
Right.
So with over 500,000 deaths, to give you perspective, we started counting HIV cases in 1981. And since then, we've had about 700,000 deaths in the US total. And we're almost there with COVID in 1 year.
Right, in a year.
So yeah, no, it's not business as usual. There is nothing business as usual.
And part of the sin, I will say, of what happened under the prior administration is trying to treat it as business as usual and trying to say that this is just like the flu. And, I'm not going to wear my mask, I'm not going to do this, I'm not going to do that. Not realizing that we are in this. And even now, today, people are still trying to say, well, all these deaths aren't due to COVID. No, they are due to COVID. And they're probably even more because we have not been counting since the very beginning. So, yeah, this is unprecedented.
I have to
worldwide and in the United States.
I have to have a excuse me, doctor, in here. Excuse me, doctor. Our next question comes from Ellen Claire Lamb. Will we need to be vaccinated for COVID-19 every year the way we're vaccinated for the flu?
Dr. Kassaye?
So my answer to that is we don't know yet, but we should be prepared to do what it takes. We are learning as we go here. And we need to be nimble and we need to make adjustments with kind of our plans depending on how things pan out. So if these variants are different enough that we need to make adjustments to the vaccine to keep us at this high level of efficacy, to keep people from getting very sick, hospitalized, and from dying from COVID, if we need to do that, you know, our researchers are already thinking about that and looking ahead. And we need to be ready as a community to listen, to look at the facts, and then to look for guidance. And again, act from a place of knowledge and trust and not from fear and distrust.
So, Dr. Mel, we have one more question from our viewers, and it comes from Conchita Mays. A lot of mazes tonight.
We're not all related.
I'm not all related. How long should one have to wait before getting another test after testing positive? Is it necessary? Does this vary by state?
Yeah, so really the guidance says you don't need to be retested if you've tested positive for COVID-19. And as far as deciding, knowing, well, when can I re-enter society, you want to wait until all your symptoms have resolved and you've been at least 24 to 48 hours without a fever. It's not necessary to get another COVID test because the test may remain positive long after you are no longer contagious. So, they could just keep getting tests on you and tests on you and tests on you. You keep testing positive, but you're actually perfectly fine and you're not going to infect anybody. So that's why the guidance about re-entering society, coming out of quarantine and isolation, that's why it's not tied to whether you test negative or not.
Yeah.
Okay. So a question to either one of you, or so recently I've had friends battle through COVID and really win. And should they be trying to get into this study, this antibody study, or donating their antibodies? Any recent COVID?
Dr. Kassaye?
Yeah, so I think anyone who is a month out from when they tested positive, they're fully recovered, they have their energy and are willing to donate. Yes, I mean, the Red Cross, any of the blood banks in your area may be accepting plasma and especially convalescent plasma. So please do look into that and donate if you find that this is something that will make you feel good. Again, as many people participate and are a part of us, fighting against COVID, it's good for all of us.
And I think it's key that remember that 1 month after you've recovered part, because, you want to have all your strength back before you donate the plasma.
Yeah.
Okay. We have one last question from Conchita Mays again. She says, thank you.
Thank you, Conchita.
Yeah.
What if you have never had a fever? I don't understand that, but I guess she didn't have symptoms with hers.
And is she talking about COVID or is she talking about the vaccine?
COVID. There's one more question from a listener, a viewer. Why I say listener? Listener, because this goes to radio eventually. There's a developing blood shortage in our area. So can either one of you speak to that? And that's from Edie Clarke Barnell.
Yes, Nurse Meady.
I'm sorry.
Yeah.
Media.
I wasn't aware of it, so I'm glad that she mentioned it, but I would imagine that just as healthcare, people are afraid to go for their routine healthcare checkups and even go to the emergency department if they have scary things like chest pain or things that they ordinarily would have gone to the emergency department. I'm sure that same reluctance is probably affecting our blood bank supply. And so for that reason, I would encourage everybody, if it's something that's healthcare related, don't be concerned. Mask up, keep your distance, know that healthcare facilities, including blood banks, have adequate ventilation and follow the precautions to keep you safe. So if you're somebody who is inclined to donate blood, please don't let the pandemic keep you from doing that, because blood is needed. So thank you, Nurse Bardnell, for reminding us about that.
All right. Lila Mays, anything from the West Coast?
No, that's all I have.
I think
it is time to wrap up. So I want to thank you, Dr. Kassaye. You have been a fantastic guest. You're full of not just knowledge, but you know how to communicate the knowledge so that everybody can understand it. And so thank you so much. Thank you for what you do. Please remember, everyone, about convalescent plasma. Now you know about it. There's also a trial, too, that's going on at Georgetown if you're interested. Is there a way that if people are interested, they can reach out to you?
Sure. If they go to covidplasmatrials.org, you can find the information there and reach out to us. And reach out to us for healthcare questions. Always happy to answer.
And I have to say, I didn't know that you're affiliated with Unity Healthcare. I'm the past board chair. So
I see most of my outpatients there. Yeah.
Yes. So I'm really happy to know that they, of course, I know they have the top-notch physicians there. And for everybody, that is a federally qualified health center, what other people may refer to as a free clinic or a community health center. So thank you to my wonderful co-producers for those excellent questions. And just thank you to the audience for joining us this week. We will be back next week, same time, 9 p.m. East Coast time. And I will be on the Russ Parr Morning Show at a new time every Tuesday at 8:50 a.m. And tomorrow night, there's a really special town hall that I'm going to be participating in as a panelist called Black Women and COVID-19. It has, it's all these different Black women's organizations, 100 Black women, all the Divine Nine sororities, the National Council of Negro Women. There will be leaders from all of them speaking on this panel, including me. I'll be there as well. And you can get to it on Facebook and YouTube by going to blackdoctor.org. So if I see you in one of those places, great. Until we meet again, please remember to be wise, be well, and be health empowered. Thank you so much.